My name's Andrew Wilson. I'm the Chief Medical Officer for the Victorian Department of Health. And we'd just like to welcome our Victorian and interstate participants to the stroke webinar. And this is celebrating the release of the Endovascular clot retrieval protocol for stroke, which is a Victorian protocol. And I'd like to welcome our presenters tonight. We have Peter Hand, who's the clinical lead of the Victorian Stroke Clinical Network, Peter Mitchell, who's the Director of Neurointervention at Melbourne Health, and Bruce Campbell, who's the Director of Hyperacute Stroke Services at Royal Melbourne Hospital. And it's very exciting to have this service developed in Victoria. And Royal Melbourne Health is the first designated clot retrieval centre in Victoria, and it's the only comprehensive stroke centre in Australia. And I think, as we all know, and certainly from their pivotal publications in the area, that they're a world leader in the area of clot retrieval for stroke, and in fact in stroke care and stroke research. And I'd also like to welcome Professor Chris Bladin, who's the clinical head of the Victorian Stroke Telemedicine Program, and he'll be presenting on the role of the Victorian Stroke Telemedicine Program in supporting ECR for regional patients. So without further ado, I'll leave you in the hands of your expert panel of speakers and pass on my congratulations for launching this service, and I hope you enjoy your webinar. Thank you.
Thanks very much, Andrew. It's Peter Hand here. I am the clinical lead of the Victorian Stroke Clinical Network, and it's my job to introduce the strategy to you. We thought a webinar would be a good way to run this. We want to familiarise you with how you can access the statewide ECR strategy. We want to give you an opportunity to understand what happens to your patients at all points of the process, and perhaps explain a little bit about how we've come to develop this strategy. So as Andrew said, we have 4 speakers. I'll briefly discuss the background to the strategy. Then we have Bruce Campbell, Head of Hyperacute Stroke at Royal Melbourne, who will discuss patient selection for endovascular clot retrieval, including the critical role of imaging. The very important and professional Chris Bladin will be discussing patient transfer process and how that links in with both the VST program and for metro hospitals. And then we have Peter Mitchell, who is the Head of Neurointerventional Service at the Royal Melbourne Hospital and an absolute world expert on endovascular clot retrieval. And he'll be describing really what happens with the procedure and what it's like as a neurointerventionist, some of the issues that arise when the patient arrives at the ECR centre. So it promises to be an interesting night. I'll try and get through mine as quickly as possible. Firstly, I just wanted to say that really 2015 was a massive landmark year for stroke treatment. Now, of course, we've had many advances over the years, but we all knew that the most devastating strokes are those due to large vessel occlusion. And in those patients, TPA intravenously is really a poorly effective treatment. So we needed something better than TPA to try to help our biggest and most severe strokes. We've thought long and hard and for many years about direct approaches using endovascular measures to remove the clot. It makes logical sense, but 3 earlier pivotal trials, the IMS3, Synthesis and MR Rescue, were neutral or negative, and so it was fairly clear that different approaches were needed to answer the question. So in 2015, it was the landmark year. This was the journal edition of the New England in early February 2015, when there was the simultaneous release of 5 positive trials showing that endovascular clot retrieval works. These trials were really different from those earlier 3 trials because they showed more effect, or they used more effective devices. They had faster treatment, so faster time to groin puncture, and most of the studies used some degree of imaging selection to choose the right patient to give ECR to. And in the right hands and in the right patient, it seems to work incredibly well. This is a slide taken from Bruce's Lancet Neurology paper looking at the impact of endovascular clot retrieval, and it shows there's a treatment effect across all of the 5 major trials, with a number needed to treat of somewhere between 3 and 7. And you can see that there's a fair amount of variation in the absolute benefit. Looking at Extend IA, the trial on the right, the Australian trial, a very impressive 70% of responders who received endovascular treatment, a little bit lower, say, in the Mr. Clean trial, the one on the left. And we think that that variable absolute benefit relates to selection of patients, speed at which they get recanalisation, and the degree of recanalisation success. Now, I know Bruce and Peter will be discussing the Hermes individual patient data meta-analysis in more detail, but essentially Hermes put together all the major 5 trials in an individual patient meta-analysis. And the headline from what I want to say is every 2.5 patients treated, one patient has less disability. For every 2.6 patients treated, one patient has less disability at 3 months. For every 1 patient treated, 1 extra patient is independent at 3 months. So it's fairly clear that ECR is a massive treatment with a massive treatment benefit. But what was the state of play in Victoria at the end of 2014? Well, here's a map of Victoria with all the strokes, most of them around the metro region, and metropolitan hospitals. Some had 24-hour access to clot retrieval, others had limited access. Many hospitals were referring to Royal Melbourne, but there was really no set transfer protocols and not always an ability to accept the patient. What about regional hospitals where many patients are having strokes? There was no formal transfer policy. And at the end of 2014, VST was in place in a few centres, but there was no formal plan as to how we would roll out ECR. And looking at the department level, really the Department of Health had no idea how many ECR procedures were being performed because there was no DRG. So it's clear that we do need a statewide ECR strategy, an approach to ensure that all Victorians have access to ECR. It's important that we understand ECR is part of a broad spectrum of high-quality stroke care, including stroke units, IV TPA, appropriate transfers, and an appropriate avoidance of transfer. But what we wanted to do was make sure patients could get ECR. So we wanted to designate state providers of ECR so that patients could be referred in, and we wanted to collect data so that there could be confidence that the system actually worked. It was very clear to us as clinicians and also to the Department of Health that this requires a system-wide approach and response. And the Minister for Health, through the Department of Health and Human Services and the Victorian Stroke Clinical Network, formed an ECR steering committee to develop this process, which we're presenting to you this afternoon. It's had broad representation from the network, from stroke clinicians around Victoria, from neurointerventionists, from regional centres, the VST, the Victorian Stroke Telemedicine Program, Ambulance Victoria and the National Stroke Foundation. The first thing we did was select Victoria's designated ECR centres, and the principle here is that if we can centralise services, we result in higher volume. Higher volume equals better outcomes and fewer complications. And it also has the advantage of building capacity to train the coming generations of interventionists and stroke physicians. The ECR expert panel considered expressions of interest from various centres around metropolitan Melbourne, and 2 centres were designated as state ECR providers. Royal Melbourne Hospital immediately, so that was about September last year, and Monash Medical Centre, which will come online in about June this year, if all goes well. The other centres that are performing ECR, the Alfred, Austin and St Vincent's Hospital, can all continue to treat patients, but they are not state designated centres, so they don't have to take transfers. So what are the criteria to be a state provider of ECR? You must have a 24-hour interventional service, including a dedicated stroke physicians to back up the neurointerventionist. You must be able to accept referrals from external hospitals so that external hospitals can refer in confidence. And of course, you must be able to provide comprehensive stroke care across all facets of stroke care, including access to neurosurgery. So we believe those 2 state-designated centres, Royal Melbourne and Monash, do fulfil those criteria. Now, we can have a state-designated centre, but we really need a way that patients can access ECR. This requires considerable reorganisation of health systems, and really the key is time is brain. The key steps are we've got to identify the appropriate patient clinically. We've got to arrange and report brain imaging. We've got to communicate with our neurointerventionist, and we've got to get the patient to the angio suite as soon as possible. Key partners in this process are ambulance, TPA centres in rural, metro regions, the Victorian Stroke Telemedicine Program, on-site neurologists, particularly in metro regions, and the state ECR providers. And when you look at that map of strokes in Victoria, it's clear that more than 95% of strokes are within a 60-minute drive time of a TPA centre, most being metro are much, much closer, and at least 90% of regional patients are within a 3-hour drive from an ECR centre. So most Victorians are able to access this if we can get the system right. So here is a picture of the map, the flow map that we've developed, and we're really going to go into this in more detail in the coming talks. But basically, this is about getting the patient with stroke symptoms through to the hospital as quickly as possible, being clinically assessed, receiving imaging, and then a treatment about whether this patient is eligible for IV TPA. At that point, we need to start thinking about clot retrieval. In fact, we need to think about it all the way, but we then need to make a critical transport decision, which Chris Bladin will be talking about. We're hoping that most patients will be able to go via Ambulance Victoria via an inter-hospital transfer to the Endovascular Clot Retrieval Centre, where they're going to meet Peter Mitchell. And hopefully patients will get ECR, but not always. Sometimes they don't get ECR, and we'll talk a little bit about that. After they've had their ECR at the hospital, Monash or Royal Melbourne, as it is at the moment, we're hoping most of these patients will return home. So we're going to go into this in more detail, but you'll see that we've really divided the state up into metropolitan and VST sites, with the vast majority of regional sites having access to VST, with the VST neurologist having a key role in a lot of these decisions. So we'll go into this in a bit more detail, but that's how it's going to work, and we're hopeful that it will work quite well. So I did mention that there'd be statewide data collection. We really need to monitor performance to ensure that our results are in line with best practice. It allows all centres to improve their practice. It allows us to work with ambulance to optimise transfers and make sure we can get patients down in time. And it's really a transparent way for all of us to see that the system actually works. And I'm certainly confident that it does work. So we've developed an ECR data set working closely with the Australian Stroke Clinical Registry, and we're going to monitor this. There's an ECR monitoring committee which will be set up and will meet regularly and feed back to the appropriate people. And also importantly, the Department of Health and Human Services has developed an ECR DRG. They can keep track of what's actually going on. So look, it's a very exciting time. Here's the statewide protocol again. Community recognition of the stroke. Get the stroke into hospital quickly, get them assessed rapidly, to make a decision to pursue ECR, arrange the transfer, get them to the ECR centre so they can see this very attractive man whose name is Peter Mitchell, who's going to be talking to you soon. So I think it's exciting. It can happen. It will happen. It's been happening already. There's been 30 endovascular clot retrieval procedures in the last 2 months alone at Royal Melbourne. At least 2/3 of those have been transferred. So it can happen, and it is happening. And we hope that by the end of tonight you'll understand better. So I'm going to pass over now to Bruce Campbell from Royal Melbourne, who's going to discuss the patient aspects. So over to you, Bruce.
Thank you very much, Peter. So it's a great pleasure to talk to everyone tonight, and hopefully have lots of questions by the time we've all finished this. So I have a few hats, but I'm representing both NSF and the Royal Melbourne, obviously. So this protocol that you can see and you can actually download from the website at the moment is to really get patients, the right patients, to ECR as fast as possible, which requires both clinical and imaging selection. So that's what I'm going to be talking about. Which clinical and imaging criteria are we interested in? Peter showed you the top line of this Hermes individual patient data meta-analysis, which has a very powerful effect, but I'm going to go through some of the subgroups. So the first thing is, what about patients who can't get TPA? Either they're beyond 4.5 hours or they've got a contraindication, bleeding risk, whatever, and they can't get TPA. Well, those patients ineligible for alteplase definitely benefit. You can see there that they have a highly statistical significant benefit, even though there weren't that many of them in the trials. It's a clear-cut benefit. So they should still be considered for ECR even if you can't give TPA. So do you think the other question is, well, if you're going to do ECR, do you still need to give TPA? And the answer to that at the moment is certainly yes. All the trials gave TPA if the patient was eligible. Even though TPA didn't open the artery that often in trial patients, it was less than 10% of them by the time they got to angio had opened the artery with TPA. But there are sometimes extended delays obtaining ECR. There are times that the ECR procedure can't get the artery open, and TPA may well be helping with some of the smaller distal emboli and softening the clot. So for the moment, the answer is yes, if they're eligible for TPA, they should have TPA first and then proceed on to ECR. What sites of vessel occlusion? Well, here's an angiogram. You can see there that we have, I'll just get my laser pointer up. So we've got the carotid artery. Anything that's blocked in the carotid, particularly in the terminal segment, but even in the neck, is a target occlusion. The M1 segment, which is this horizontal segment before the Sylvian fissure, is where most of the occlusions were in the trials. And then M2 vessels, the proximal chunky ones, Peter might talk about this a bit more. Once you get beyond about here, the vessels are starting to get a bit small and tortuous, and at the moment that's not the territory for ECR. So we're really talking carotids, first part of the middle cerebral, just into the Sylvian fissure, but not much beyond there. Those smaller vessels. So basilar artery, of course, is also eligible. That's being treated outside the trials for many years, and we would continue to treat them. Tandem occlusion means an occlusion in the cervical carotid as well as the intracranial circulation. That's technically more complicated. Again, Peter may talk about this a little, but these patients often need an angioplasty or a stent in their neck, but these patients definitely benefit, and you can see there the odds ratio for benefit highly statistically significant in this Hermes meta-analysis, despite the technical challenges. What about age? This is the classic issue in stroke. Older people don't recover as well, but they still do a hell of a lot better if you treat them and if you leave them alone. So here is the forest plot showing the over 80 group have a highly significant benefit. The magnitude in odds ratio terms is at least as great as the younger patients, perhaps even greater. If we put that in another way, you can see here this is looking at the disability outcome with 1 being better and 0 being dead. And you can see that although outcomes drop off with age, there's a parallel line here between the two treatment groups. Endovascular are consistently better than TPA across the age spectrum with no evidence of heterogeneity in treatment effect. Clinical severity, most of the trials had some minimum NIH score, and most of the trials it was around 6. In Extend-IA we didn't have a limit. In Mr. Clean it was only 2. Within the range of scores that we've seen in these trials, there is no heterogeneity in effect. So we would look at the vessel occlusion, make sure there's a clinically important deficit, but we're not too fussed about what the NIH is. And there again are the parallel lines of treatment benefit. Again, the more severe the NIH, the worse the patient will do on average, but there's still a treatment benefit across all levels of the NIH. Time window, this is a little complicated. For the moment, we will say that we would prefer to start the procedure within 6 hours. So this is data from Mr. Clean, where they had a fairly unselected population, and if you achieved reperfusion, there was clearly a treatment benefit over standard care, with confidence intervals crossing 1 just around 6 hours. Now, there are other studies which have used imaging selection, such as the Diffuse-2 study, where that time relationship is not present. And we may find as we go forward that these rigid time windows disappear and we move more to imaging selection. But for the moment, we would really want to try to get patients treated, of course, as quickly as possible. As you go further along, the proportion of patients who will benefit decreases, even though there are some individuals we might be able to select out. So regardless of these curves, the message time is brain holds. We still need to get patients down from their peripheral hospital to the ECR centre as quickly as possible. Every minute counts. So this is leading up to what's in the guidelines. So we have guidelines for eligibility, proven vessel occlusion on CT angiogram of the internal carotid middle cerebral artery M1 segment, that's that horizontal segment before the bifurcation, and the early M2 segment and the basilar artery. We want people to have independent premorbid function. Obviously, if someone already has disability, it's very hard to get them to an independent outcome. We want to start the procedure within 6 hours of onset. There is some discretion for basilar artery occlusion and for selected anterior circulation patients beyond 6 hours with CT perfusion, etc. But in general, we're going to stick to the 6 hours for now. If they are eligible for TPA, that should be commenced. The other thing that needs to be assessed, and that's where the interventionists particularly need to be able to see the imaging, is the access. So the aortic arch can be tortuous, it can be difficult. Peter and the team need to be able to look at that remotely to make sure they can actually access the artery. So I'm now going to move on to the imaging aspect of things. That was the clinical side, this is the imaging. What do we get from a non-contrast CT? Well, obviously we exclude hemorrhage, we exclude a large hypodense established infarct. We're looking for subtle ischemic changes that tell us that there's irreversible damage, loss of grey white differentiation. We're very interested in hyperdense arteries, and I'll talk again and again about thin slice CT as a way to increase your recognition of hyperdense arteries, and also non-stroke pathology. This is an example of a hyperdense artery here in the right middle cerebral. That's the M1 segment, got a long segment clot there. This is subtle grey-white differentiation loss in the caudate and lentiform. The insula is preserved there, and you can see that that must have been a proximal right MCA occlusion at some stage, and that's irreversibly damaged. It doesn't change the decision to thrombolyse or give clot retrieval. It just confirms the diagnosis of stroke and tells you there's going to be a basal ganglion infarct no matter what you do. This is less subtle grey-white differentiation loss. You can see the normal side versus the abnormal ACA territory infarct. And here's a more distal occlusion. This one is up in the Sylvian fissure, and if that's the only, that's the most proximal extent of the clot, then that is too distal for Peter and the team to go and fish out with the current range of devices anyway. That may change in future. So we usually do 5mm slices. If you look at the middle cerebral artery here, you can see that it's not particularly hyperdense. You wouldn't look twice at that. Whereas if you get a 1mm thin slice through there, you can see it's clearly hyperdense, and that gives you about a 90% sensitivity for large vessel occlusion. It's simple partial voluming principles. In the 5mm slice, you might have 1mm of bright artery and 4mm of dark CSF, and so the average is just grey, whereas a 1mm slice directly through the artery makes it very clear that you've got a hyperdense thrombus. This is free information. Radiographer just has to press a button. There's no extra contrast radiation or anything else. It's just about identifying this from the non-con scan. So, CTA is critical for identifying vessel occlusion. It's diagnostic if you're uncertain about the diagnosis, like you're thinking maybe seizure at onset with a Todd's paresis or a migraine or something. It helps us with mild stroke because we know mild stroke with vessel occlusion are a group that have a high risk of later deterioration. Even with an NIH as low as 3 or less, about 10% of patients have a large vessel occlusion, and about a third of them later deteriorate, usually beyond the window when we've had a chance to intervene. 30% of the mild strokes that we deem too mild to treat, if they've got a vessel occlusion, they end up disabled, and not enough of them get back to all their usual activities. Vessel occlusion with CTA also tells us about basilar occlusion, which is not always as clinically obvious as you might think. The most common presentation is actually a hemiparesis rather than the classic tetraparesis, and some of the other more subtle eye signs and things can be missed in the hurly-burly of the acute stroke assessment. So basilar occlusion, also in patients with coma of uncertain origin, is a really important diagnosis to prove with a CT angiogram. It also tells us about the proximal access, the carotid stenosis or occlusion or dissection, which informs our management. It tells us about the target vessel for endovascular clot retrieval. And you can potentially look at CTA source images and CTA collaterals, although you have to be careful in interpreting them. We can talk about that later if you like. CT perfusion, quick plug, it's actually easier for the radiographer to do than a CT angiogram because you don't have to time it. You've already had to get intravenous access to do a CTA and draw up contrast, so none of that's extra time. And there's automated software available now that can produce maps without need for radiographer expertise and time. So it gives you information that's much easier to identify a perfusion abnormality than some subtle vessel occlusion. It's more sensitive than CTA for the smaller occlusions, and we can tell quite a lot about what tissue is salvageable versus dead. Certainly easier than trying to score collaterals on a CTA. Has the potential to extend the time window for treatment. So there's the summary table in the protocol for brain imaging. So we must do a non-contrast CT, strongly recommend that you do the 1 millimetre thin slice reconstruction so that we can detect hyperdense arteries. CTA is absolutely mandatory. If the patient hasn't had a CTA, the endovascular team won't call in all the cavalry. So it's essential that we get the CTA done at the referring site. Gives us all those advantages I've talked about, and I just mentioned there is no requirement to wait for a creatinine result unless you know there's severe kidney disease and you really think it's critical that you wait. I would think in most situations this is an emergency, it's a life-saving procedure, and you should just proceed with a CT angiogram. We're going to give them intravenous saline post-hydration. The incidence of contrast nephropathy is grossly overstated. CT perfusion I would strongly recommend. It helps your diagnostic confidence and it gives you a very good idea of what we're going to achieve and improve our prognostic discussion with the family. So how do we integrate it all together? Well, other people are going to talk more about this, but I really want to emphasise using the ambulance pre-notification. We're fortunate in Victoria that Ambulance Victoria will pre-notify any suspected stroke within 6 hours, and that should be passed on from the emergency department team to the stroke team so that you can meet the patient at the door, go directly to CT on the ambulance stretcher, which saves about half an hour, and then do your non-con CT with your thin slices. You can activate VST or your endovascular physician call as early as possible. If you've just seen a hyperdense artery, I'd prefer to know about it then and as you're acquiring the CTA, and we can discuss all the other elements of eligibility and get onto the interventional team as quickly as possible. We need to make sure that all of your hospitals, we can access the imaging, so we're not trying to hub and spoke things that take way too long. And then when you arrange transfer, this will get brought up again, you call 000. You don't call ARV unless there's a hemodynamic or a respiratory problem that's going to require medical escort. So most strokes, 99% of them, physically in the anterior circulation, will just be a standard 000 call. An ALS paramedic can take them, they don't need mica. And the thing is to request a sub 15-minute response time so that you get a lights and sirens response. So I'll just give you one last quick question. 70-year-old guy, dense left hemiparesis and dysarthria. He's last known well at 9:30 and you're seeing him 3 hours later. You've got a CT scan, which I'll show you, and you've got a VST call, and he's got TPA going. So is this patient eligible for ECR? And I think Laura's going to kindly pop up a little poll for you, and you can all vote on this. So would you send this patient for ECR?
Unanimous.
This is looking good. So we got 100%, which is well over. Yep, we're okay. I think we got the point. This is a classic case, perfect patient for ECR, and we'll close that. Thank you. So, I was meant to show you the CTA. Sorry. So you do need to get the CTA to make sure that the patient's eligible. This was actually a case where the CTA wasn't done on site, and that meant that he came to Royal Melbourne, he had to be imaged there, and then we could call in the endovascular team, which caused quite a delay. So really emphasise that CTA at the site is the way to go with this. I think that's my last slide, other than to thank the wonderful team that I work with at Royal Melbourne, and to look forward to your questions.
Excellent. Thank you very much, Bruce. We might hand over to Chris Bladin at this point.
Thank you very much indeed. I hope everyone can hear me clearly. My role today is to really fill in some of the gaps here in terms of how we manage stroke patients in regional sites, and as you can see from the title slide here, looking at endovascular clot retrieval for acute stroke, and it's really the role of Victorian Stroke Telemedicine. And many of you will already be familiar with the VST program, but for those perhaps who aren't, I'm just going to briefly go over what this entails. Now, Peter has already highlighted the nature of Victorian strokes. There's about 15,000 strokes each year that do occur, and we have worked very closely with Ambulance Victoria to produce what is known as an isochrone map. This is a map that looks at basically literally connecting the dots, but doing so within a defined time frame. And you can see from this map, this isochrone map, we have the lightly shaded areas which indicate a 1 hour drive time to a regional centre, and the pinky purple shaded areas indicate about a 3 hour drive time to to metropolitan Melbourne. So this has been a very important mapping process for us, because it has allowed us to identify not only where strokes occur, but where we need to place the regional stroke centres, where they need to be set up. And as you would anticipate, these will be largely based at the regional hospitals that you can see located on the screen. And as Peter highlighted during his presentation, over 90% of suspected strokes that occur in Victoria, and indeed to a certain degree in southern New South Wales, will be able to access acute stroke services at each of these regional sites. And they will be able to do that by use of VST. And VST is a program that is funded by the federal government. It's rolling out to all 16 regional hospitals across Victoria, and we are in the final stages of that rollout. And I'm just going to take you through what the VST program actually entails. So how does VST work? Well, as we've talked a bit about today, we need the pre-hospital component to work well, and when family, friends or neighbours or whatever find someone who had a stroke, it's imperative that 000 is called, that the patient is transferred to the nearest appropriate regional hospital, and that the paramedics notify the hospital prior to arrival. When the patient arrives in the emergency department at the regional hospital where VST is established, the team there calls 1300 telemed. It's a single number for the whole of Victoria, and then that puts the medical team at the hospital in contact with a roster of neurologists that are available 24/7, 365 days a year. And the next available person on the roster is then contacted by dialing the number 1300 telemed, and we're then able to undertake an assessment by the stroke specialist. And that will involve obviously looking at the brain imaging, but also doing a video consultation with the family and the regional-based clinician. Decisions can then be made about what is the most appropriate therapy, and certainly for ischemic stroke, the strong consideration is whether TPA thrombolysis needs to be commenced, but also then, as we've heard already, consideration needs to be given as to whether the patient is suitable for transfer to Melbourne for endovascular clot retrieval. And I won't go into the imaging components of that because Bruce has already covered that very well during his presentation. So let's quickly look at what we actually do, what the equipment is that we use during the stroke telemedicine call. And we have a German company with some excellent technology called MyTech, and this is their cart, and some of you may already have this situated in the emergency department at your hospital. This is a sort of a comprehensive system. It's not just the hardware with the computer and the screen and the camera, but there's also a very important software component to this. And when a call is made, we are able to identify, obviously know which hospital is calling, and then we're able to initiate a call, and you can see all the hospitals are listed down here on the left-hand side. We then choose the hospital that is calling us. We then hit the call button, and we're able to get direct access to the medical nursing teams at that regional hospital, and we're able to do an audio-visual consultation. We may have the patient in the bed, but likewise we may also have discussions with not just the medical teams, but also with the family that may be there as well. But this is not just an audio-visual system. There's a lot of other important aspects to this software. And during the course of the consultation, within the same software program, we're also able to pull up the brain imaging and look at all the different scans that have been performed, in particular the plain scan, but also, as Bruce has highlighted, very important that we see the CT angiogram so we can make a rapid decision as to whether not only thrombolysis is delivered, but also whether transfer for clot retrieval is going to be needed. Now, another important aspect to this software is also that we have the ability to take clinical notes. And this is a very important medico-legal aspect of the whole teleconsultation process, whereby a decision is made, but as we now know, certainly in the modern medical environment, that unless that decision is clearly documented, then in essence that decision hasn't been taken. So documentation is a very important part of this process, and we have a bespoke stroke telemedicine form that has a series of drop-down menus and is easily able to be completed. And we have a goal of getting that back to the referring hospital within 1 hour of the consult having taken place. And that's important because that can then be filed in the patient's medical records. So things have been busy of late with stroke telemedicine. I've just got a few little front pages and tweets and so forth that have happened, and we've had a lot of success stories in terms of being able to not only treat patients on site, but also get patients down from regional centres and get thrombolysis and endovascular clot retrieval underway. And you can see this very happy camper who was up in Albury, and he got down in time and made a fantastic recovery, was able to return home to his family and to continue his house renovations when at the outset he had quite a severe stroke. So a lot of positive stories coming out of the telemedicine program and the capabilities of transfer down to Melbourne for clot retrieval. But things have changed, and we really need to look to the future. And as we talked about, this is not just about delivering TPA in regional hospitals. It is very much about clot retrieval, and we've already seen this document here, which is available for download today, the clot retrieval protocol that is now statewide across Victoria. Peter Hand has already shown you this diagram. It's a little bit complex, and I'm not going to go through this in individual detail, but I think the following slide, as Peter said, really sort of sums up what this program is about. It's about community recognition, that rapid transfer to hospital, dialing 000, getting the patient to hospital as quickly as possible, pre-notification of the emergency department, and then in terms of VST, the role of the VST neurologist. So once we're called, we're able to ensure that the appropriate imaging has been done, give advice on that. We're able to make decisions regarding thrombolysis. We're able to look at the CT angiogram and make a decision as to whether this patient is suitable for transfer. Having done that, we can then be in communication with the team at the Royal Melbourne Hospital to ensure that that can proceed smoothly, and we will get the medical team at the regional hospital to contact 000. We predominantly work with Ambulance Victoria rather than ARV, and we then look at getting the transfer happening as quickly as possible. And that may happen in a variety of different modes. It may be by road transfer, it may be by fixed wing, or as we've seen of late, we're now having a number of helicopter transfers as well. But this area of the flowchart is really where VST has a strong role and is able to coordinate that regional treatment, but also the transfer process down to the Royal Melbourne Hospital. So VST has now been running for a few years, and really things have stepped up dramatically over the last sort of 6 months or so. We've now, in the last 2 years, we've completed well over 500 VST calls. We've given thrombolysis to almost 100 cases, and as we've talked about today, there's been at least 15 cases referred down for consideration of endovascular clot retrieval. And this program, the VST program, works very closely. It's aligned fully with the Royal Melbourne Hospital. We're currently based in the Flory, and we do a lot of data collection through OSCAR and data analysis, and we feed that back not only to our colleagues at the Royal Melbourne Hospital, but also importantly back to the Victorian Stroke Clinical Network. And as Peter Hand has indicated, there are new governance committees being established to carefully monitor the works of the ECR protocol and to fine-tune this as needed. VST again is across 16 hospitals in Victoria. Our rollout will be completed by the middle of this year. So I thought I'd wrap that up at this point and hand over back to you, Peter.
Thank you very much, Chris. So our final speaker for tonight, and hopefully we'll have some time for questions afterwards, is Professor Peter Mitchell, who is Director of Neurointervention at Royal Melbourne Hospital. And it's a great pleasure to welcome Peter.
Thanks, Peter, and thanks for everybody for joining us for this discussion on the endovascular clot retrieval service. And I thought I'd try and give a perspective from the neurointerventionist. There are some issues that often arise after the referral to the endovascular clot retrieval specialist. We've now got 4 people on staff, Rick Dowling, myself, Bernard Yan, and recently joined by Steve Bush. So we have been providing a 24/7 service for the last decade. But some cases that get referred to us aren't appropriate or can't be done. And just to clarify some of the issues around case selection that Bruce has already touched on. You're well aware of the problem, the occluded vessel with no flow. If we can recanalise that early, we minimise the size of the stroke. And what we're trying to do is to arrest this progression from the red infarct eventually filling the threatened tissue. Now, we've heard that time is brain, and we reiterate that at every single point, that in the individual case, the earlier you can treat the patient, the better the outcomes are likely to be. However, we do recognise that there are some people who are slow progressors, and in those patients, the time may not necessarily be the best guide. We know that up to 6 hours after stroke onset, we think patients should proceed to endovascular clot retrieval if they meet some criteria that I'll touch on in a minute. But that's not to say that there aren't some patients who are in this early phase even at 8 or 10 or 12 hours. So that's when the CTP or even MRI, perfusion and DWI can help us choose to treat patients who might be outside some of our time limits. So we're not absolutely rigid, but I'm trying to give a flavour as to what issues will be around whether we proceed with treatment. Because there are many patients who get transferred to us who, with all of the best intention in the world, arrive late. Now, what we don't want to be doing under any circumstances is treating people who are at this end. Now, you can't see that because I haven't touched the pen, but I got the pen here. Yeah. Thanks, Bruce. I don't know if, the area, we don't want to treat patients who have already got a large infarct. They're not going to benefit. All we're going to produce is harm. Now I think I can see my pointer. Yes, I can. Thanks. We've had mechanical devices available to us to remove clot for some time. There's nothing particularly new here, except these devices, which we used in some of the earlier negative trials, were not positive. They did not achieve reperfusion. You wonder why they didn't make devices that were stiffer and could grab onto the clot. Well, the risk is that you perforate these blood vessels. It's very easy to perforate intracranial thin arteries. If you perforate somebody who's also just recently had some TPA, it is usually fatal. So there's been this conflict between having a device that's flexible enough to go up into the distal vessels without causing harm, but at the same time be robust enough to retrieve the clot. And I think that's been the big issue where those devices failed. What we did learn from these early devices is that combining them with a balloon guide catheter, this is a very large catheter, the balloon can arrest forward flow, and applying aspiration to, or suction to the guide allows the clot to be retrieved with a much greater likelihood of good retrieval. The new devices that came out, you've heard the term stent retrievers. The first one was the solitaire device. There are other devices on the market now. They're combined with a balloon guide catheter in most cases, and these are the devices that almost double the chance of achieving good recanalization and let us do it safely and quickly. What does the angio lab look like? We welcome any of the referring clinicians, nursing staff, Ambulance Victoria, to come into the lab and watch these procedures. There's usually 2 of us, and this is on a biplane system. It's a specialised system which I think makes this a safer procedure. Sometimes patients are under aspect, sometimes not. This is just to remind me that you can see that the white and the black are the same wire and the same solitaire device, and you can see the distal tip of the device in the middle cerebral artery. This patient's moving while we're doing the procedure. This patient was treated without a general anaesthetic, and in fact it's not usually conscious sedation. We prefer to do them without a general anaesthetic and with no sedation. Most patients, about 2/3 of patients can tolerate this. Most patients will experience a short period of pain while we withdraw the clot. I haven't yet found anybody who's complained about that the next day when they understand that if we can avoid a general anaesthetic, we believe we get better outcomes with a better chance of going home. Sometimes we get the images on the right-hand side of the screen, which is the clot removed in continuity, tangled on the solitaire device. However, there's a significant number of cases where we don't achieve that, and in those cases we still get good recanalization if we've used the balloon guide catheter, because you aspirate these clot pieces that come out in the syringe rather than on the device. So it's the total procedure that determines its effect. What does it look like? This patient, one of the key advances which has been touched on is CTA. When the early trials were done, CTA was of poor quality, was on scanners that had 4 slices or 16 slices, and the image quality was very poor, and so we didn't know who had a large vessel occlusion. And most of the trials suffered because they included these patients into the trial. Clearly, if you don't have a large vessel occlusion, you're not going to benefit from an endovascular approach. So identifying the patients who have the large vessel occlusion is crucial. And it also is important to show us what the aortic arch and the neck vessels look like, because that determines whether we will accept the patients or we will be able to do the procedure. Bruce has alluded to the perfusion imaging, which around the margins, this is, if we have perfusion imaging, it can allow us to consider going beyond strict time limits and other such features, whereas without it, we won't be able to do that. You can see the occlusion that matches perfectly with the CTA in the proximal middle cerebral. This is the ideal sort of case. Nice straight artery. We place a very large balloon catheter a long way up the artery. If we can do this, we are confident we can get good reperfusion. If access is bad and we can't do that, it's another factor that means the procedure may not be effective. And we see the large vessel occlusion. Passing the catheter through a wire through the occlusion is going blindly through this area, and a lot of it's by feel. This is the risk when you can perforate. We inject some contrast to prove that we're still intravascular. This is when we've deployed the device. The device extends from the MCA, from this point, out to this point. You can see there's the clot. It hasn't been removed yet, and yet already we're getting antegrade perfusion. Then we remove the clot, in this case getting a TICI 3 recanalization, so that's the best reperfusion. You can see the clot's been completely removed. There it is on the device. Some of it was in the thrombus, was in the aspirate that came out of this large catheter. Bruce has alluded to the cases we want to do. We want to do ICA, carotid terminus, M1, and out to the very proximal M2. We don't believe that doing branches beyond the M2, M3 is likely to be beneficial. Certainly it hasn't been proven to. We need more data before we start treating those patients. I'll allude to some of the national guidelines that have come into existence, but with this sort of patient, there's not a lot of discussion. If we have a patient who has good premorbid function, it's in the anterior circulation with a small core, however you've shown that, and a large vessel occlusion at these sites, and we can puncture the patient for 4-6 hours. Now, we're making an estimate on that when you're ringing from Horsham or Benalla or Albury, but that's the patient we're looking for. We have good access, so we've looked at the CTA. We'll call our team in if we know we've got good access and a large vessel occlusion. And if we can do it without general anaesthesia, these are the ideal patients. There's really not a lot of discussion. If you know, Chris Bladin, if Peter Hand, if Bruce rings up and this is the story, and we can look at the imaging to prove we've got good access, this patient is a no-brainer. They should be referred. Similarly for the basilar occlusions, although I acknowledge there's no evidence, but in general we'll accept them. Another way of looking at it are the European guidelines. Again, you'll note the time limits, a large vessel occlusion, patients who have received IV TPA within 4.5 hours. The USA guidelines, again, there's a lot of very specific features here. These identify the ideal patient where there's not a lot of discussion about whether they should or shouldn't proceed to endovascular treatment. There's some evidence that outside of 6-12 hours, evidence is poorer. Whether or not they've received TPA is not that important. They should still be treated. These are easy discussions. I'll skip over this because Bruce has touched on it. I'll look at this data as well, which Bruce has alluded to, which just reminds us that we don't think we should be excluding people by age per se. However, it's certainly more likely that older people may have poorer access. So that is one of the things we still look at, but we wouldn't exclude someone on age alone. We wouldn't exclude patients who have aspects of 6 to 10, although there is a benefit in the lower groups, not statistically significant, and these are the groups we would really want further evidence, like perfusion imaging, to show that there is threatened tissue and there is something to salvage. Stroke location, we would prefer ICA or M1 or proximal M2. We agree with Bruce's comments about taking patients who have mild NIHSS. We stress that we believe this is going to benefit from centralisation at this stage with Monash Medical Centre and Royal Melbourne Hospital coming online at the end of last year, with other sites providing the service if patients are in those hospitals, but with the two sites having patients sent to them. Issues around general anaesthesia, some of the things to think about and you can raise with us to help us not have patients transferred down who prove ineligible. If we know we have to use a general anaesthetic because someone is combative or has poor premorbid function, which is another issue, they do get sent to us, people who are mild cognitive impairment, who cannot cooperate, who will need a general anaesthetic, who have multiple comorbidities. We've even found one who had an advanced care plan that said they were not allowed to have a general anaesthetic, so we had to deny them treatment at the last moment because they couldn't have it without the general anaesthetic and declined. Those are things that we should be able to identify before patients are transferred. Access has been alluded to, and this is one of the key things we assess when patients are referred. Patients who have bilateral occluded iliac arteries and bilateral amputees, quite apart from MRS issues, don't have access. We can't do those patients easily. And so if they're on the margins for whether they should be treated, that would be a major factor. Dissection, I'll show a case to show why I believe it is a problem in accepting dissection and why it's not a straightforward decision. If we have to stent somebody, it raises issues around antiplatelet therapy. Again, if we know we're going to stent and there's a large core already present, if somebody's got an aspects of 5, we would be less likely to treat someone, particularly if they're outside the 6 hours. So they're the kind of factors that we consider. We're also putting in a very large sheath to do this procedure. In a small, elderly, frail patient, a 9 French sheath has caused significant morbidity. Now, this is just an example of some of the shapes we see with internal carotid arteries. Either the aortic arch or the carotid artery can preclude access, and this really can't be solved in the majority of cases. I just close on highlighting why I think dissection can be a problem. This is a patient who came in with a mild stroke but known occlusion of the internal carotid artery, shown here, but with a patent internal carotid and middle cerebral artery and with minimal core. Therefore, they were given TPA but not for interventional treatment. However, the patient had a deterioration at 0400 with a bad stroke, already with large area of hypodensity, aspects of 6, very young patient. The internal carotid artery remains occluded. Now we've got an M1 occlusion. Internal carotid dissection, no flow into the supraclinoid internal carotid or middle cerebral artery. We look at the vertebral artery. We can see PCOM filling the internal carotid, but an M1 occlusion, no collaterals. I was able to get through that dissection once and did manage to reperfuse the middle cerebral artery, but was not able to open this artery. At the end of the procedure, the middle cerebral artery territory was reperfused, but we couldn't reperfuse the internal carotid. There was already a large infarct. If we tried to put a stent in the internal carotid artery, we would have needed to administer Plavix and aspirin. These are some of the issues. I just give you a flavour of why sometimes we'll make a decision that the risks of what we're doing are greater than the potential benefit. In the straightforward case that meets the guidelines, it's a reasonably easy decision. There are many cases on the margins. If we have perfusion imaging, we can go beyond time limits. If we know patients are going to get down here a little bit late, try and give us that sort of imaging. We're available 24/7. The Royal Melbourne Hospital switchboard has the endovascular clot retrieval neurointerventional consultants on-call phone number, so it can be contacted by the VST neurologist or our colleagues, or contact us directly. And we remain keen to implement and improve the number of these patients coming through. To date, a small proportion of the almost 100 patients we treated last year came via VST, but I think that's been steadily increasing and will continue to do so. Thank you very much for your attention.
Thanks, Peter, very much. That was a really great talk, and fantastic to hear it from your perspective, because I think often it's very hard for us to refer a patient in and then find that they don't get the treatment, but I think there are some very legitimate reasons as to why they don't. And just the postscript to the last patient you presented, he had a hemicraniectomy at 4:30 a.m. this morning. As predicted, he's had a very big stroke, so that was disappointing, but what can you do? At this stage, I think we have a couple of minutes available for questions, but I'm not exactly sure how we run questions on this system. So I don't, maybe people have a better idea of how it works. If there are questions, if people want to type questions in, yes. If you type questions into your window, if that would work well. I'm not sure if all the presenters are available mic'd or unmiked.
In the interest of everyone's pleasure, I'll turn off my webcam, I think.
It's been nice seeing you, Peter.
Thanks. I'll stay on the line.
Okay. I just want to tell everybody that if they go to the bottom of their screen, there's a little documents file at the bottom right-hand corner. If you click on the documents file, you will find within it the endovascular clot retrieval strategy, which is now officially released. You can click on that endovascular clot retrieval strategy and download the strategy and read it and see whether you like it. So I'd really encourage you to do that, because we will be working according to that strategy as we deal with referrals both at Royal Melbourne and on the VST system. So for transfers from Metro as well as from regional, we'll be working with the protocol which has been developed in consultation with many of you. So please download that now. I believe it's now no longer embargoed, and so Sonia Denisenko and I have to thank Sonia in particular for her outstanding work in getting this protocol together. Sonia and I will be getting this actually sent out in hard copy form to most of you. So if you'd like to download it, just click on that bottom right-hand corner document file and feel free to take it. There will be a hard copy coming soon. Once again, thanks to Sonia. In my little area, I'm not seeing any questions.
I've seen a couple.
Have you?
Yep, so I'll answer. Jim has asked, as a CT radiographer, where are you doing the CT? You're quite correct. It's from the aortic root, the aortic arch, up to the cerebral vertex. So we don't want to truncate halfway through the middle cerebral artery. We don't want to truncate in the neck. We want the whole system from the aortic arch up to the cerebral vertex. Yeah, there's also a question, what is aspects? And that's just a way of systematically looking at the non-contrast CT, which you may or may not want to worry about. But
Bruce, an aspect score of 10 is normal, and an aspect score of 0 to 5 is a lot of brain tissue dead. Is that correct?
It is, and basically different segments, the caudate, the lentiform, the insular and cortical segments, 1 to 6 in the middle cerebral artery territory are what you're scoring, but it's something that radiologists sometimes use. I can't say that I calculate the aspects very often. It's not particularly weighted to volume or to eloquence, but it has been validated in multiple studies as an on-average prognostic marker.
Bruce, can you hear me?
Yes.
Oh, good. I was just going to address that same issue. The covering down, what tends to happen is that the lower end of the coverage gets down to the sternoclavicular joint in many, many cases and doesn't show us the aortic arch. So we really want to see the aortic arch. That's what we get a lot of information from. And also, if possible, having access to the thin sections of the CTA is useful to us because that allows us to do our own reconstructions and works very well. Some places we only get and works very well. Some places we only get thick sections. We can't reconstruct those, and we're dependent upon what reconstructions are sent, and that's a significant limit in many of the cases.
So there's another question from Tissa about patients with bad kidneys. Is a hyperdense artery on 1 millimetre slices good enough to consider? The problem there, Tissa, of course, is to do the ECR, you've got to give contrast as well. So I think really, if you see a hyperdense artery on the slices, the thin slices, you need to proceed to a CT angiogram to get the guys to consider the proximal access. Peter can leap in if he disagrees in any way, and we'll post-hydrate them, but really the whole issue with contrast nephropathy is a bit overstated. There's a very nice series from Newcastle, Australia, where they looked at over 700 patients that all got contrast without any checking of creatinine, and there really wasn't any trouble with contrast nephropathy.
Yeah, I agree. I think if we make it a default so that if you think somebody is potentially suitable for endovascular clot retrieval, then they really can't be unless they get a CTA. I think that's a reasonable position to take.
And it's also important to do it at the same time as this non-con CT. You don't want to be taking them off the table, doing other things and bringing them back later. It just builds in a huge delay.
Bruce, I'm still having trouble seeing questions, so if you can see any, please fire away.
Ranil's pointed out that he can't download the document, so I don't know if anyone can help him with the technical aspect of that, if anyone else has managed to do it.
Okay, now I'm seeing a question. It says, question from Horsham. What agreement has been made with AV? Will they accept the transfer straight away? And the answer to that is yes. You or the VST people need to let ambulance know, ring 000 and let them know that it's a Category 1 call. You have to have the patient ready within 15 minutes because they will be there within 15 minutes to take the patient directly to ECR. We have had discussions, negotiations with AV. They are on board with this and are happy to do the transfer. And you do not need to use AVR. It's in the protocol. We shouldn't use AVR unless there is a major issue. So you can get your patients from Horsham, from Albury, etc. Ring 000 and the patient will be transferred, but have everything ready.
Yes, they'll be very upset if you're not ready when they arrive. So that includes all the documentation that needs to go with them, etc. And make sure that the TPA, if it's running, is all in one syringe so that no one has to change syringes halfway through. So it's just a matter of thinking about all the things that need to be prepared before the patient leaves the door.
There's a question about what is perfusion CT, is more contrast given. It depends very much on the CT scanner that you've got. But some of the scanners can do a CTA and a CTP in one acquisition. Others require two. It's a very small additional dose of radiation. It's a very small additional dose of contrast. and it's very, very useful. It's not mandated, but as I said, if we have the CTP, if there are delays in transfer or we get to the point where someone is marginal for treatment and falls outside of those guidelines, we're not usually going to offer them treatment unless we have more information, and the CTP gives us that more information.
Tiss has asked another question. If there's a good mismatch, would you consider clot retrieval even after 9 hours? And I think Peter again can comment, but at the moment we do have a trial that we're doing, which is 50-50 endovascular versus standard care out to 24 hours, but they need to be good candidates with great perfusion. It's something we can discuss on a case-by-case basis, I guess, but it's not routine.
I think that they're the complicated ones where I think all of us talk together and try and take into account everything.
Okay, there's just one little question here from Samara. With the CT perfusion, if we don't have the software required to make the maps, are we able to send them things to you and you can use that? Bruce, Peter, what do you think?
I think that's something to contact me offline and we can discuss that. There are various ways of working around these issues, but yeah. So hopefully you can get in contact with me. It's bruce.campbell@mh.org.au and we can talk about that.
If you've got a CT scanner that can perform CT perfusion, then that vendor will have their own maps. We may argue around how standardised, how useful, how beneficial they are, but nonetheless you will be able to get some information from your vendor's maps.
Okay, and I think there's a couple of questions about can we review the slides offline. The whole webinar is being recorded so people can do it again. I'm not sure the exact technical details, but we will send it around. Okay, are there any more questions? I'm mindful of the time. I thank everyone for joining us. We're going a little bit over, and I know Peter Mitchell has to push off. I think there's something brewing up in the angio suite. So we might sign off. We will let you know how you can review these slides offline again, and we'll talk about whether the slides can be provided. Certainly the document will be available, and again, I'd like to thank our speakers, Andrew Wilson, for introducing us. I'd like to thank Chris Bladin from the Victorian Stroke Telemedicine Program. I'd like to thank Peter Mitchell from the Neurointervention Service at Royal Melbourne Hospital, and Bruce Campbell, who's a neurologist, stroke neurologist at Royal Melbourne. You've heard three fantastic talks from three world experts in this area, so I hope it's been helpful for you. I and Sonia Denisenko are very proud of the ECR strategy that we've put together with the help of many of you. I'm hoping that it's going to work. I think it's working already. I'm very excited, and I look forward to putting it into action with everyone. So thanks to all, good night, and thanks for being part of the webinar.